It's about prenatal, I believe. Let me check the name. Prenatal Psychiatry. Doctor, do you have my name? Do you have my voice?
I do.
Okay, wonderful. Can you connect your screen? I believe you should have access. 1 second. Okay, here you go. There is a green icon at the bottom of the screen. It should come about now. Yes, okay, we have your slides.
Just give me 1 second to...
I also wanted to ask permission of whether it's okay to share the recording of your lecture in YouTube and to also share it with the participants later.
Sure, happy to.
Is that okay?
Happy to have it shared.
Okay, that's wonderful. Thank you.
Do you have my slides?
Yes, your slides and your voice are perfectly okay.
Okay, thank you so much. من ادوین رافی هستم، روانپزشک. من متخصص روانپزشکی زنان و همینطور اعتیاد هستم. باعث افتخار منه که امروز اینجا باشم. همیشه آرزو داشتم که نقشی داشته باشم در ارائه و گسترش روانپزشکی زنان در ایران. من واقعا باور دارم که در دنیایی که جدا کردن مردم و دور کردن انسانها آسون تر شده، ما میتونیم پلهایی بسازیم با تبادل علم، با تبادل هنر، با تبادل موسیقی تا انسانها و دنیاها رو به هم نزدیکتر بکنیم. امیدوارم این دریچه‌ای باشه، شروعی باشه، پلی باشه برای این قصد که ما روانپزشکی زنان رو در ایران گسترش بدیم. میخواستم از INRP، از انجمن علمی دانشگاه علوم پزشکی تهران و تیم شما، خانم نیکی مهجوریان و تیمی که این سیمپوزیوم تشکیل دادن برای این فرصت تشکر کنم، چون دیدار بین‌المللی هست. من از اینجا به بعد رو به انگلیسی صحبت میکنم. Thank you for being here. I'm a perinatal and reproductive psychiatrist at Massachusetts General Hospital Center for Women's Mental Health and instructor in psychiatry at Harvard Medical School, and the director of behavioral health for the MGH Hope Clinic, which is an integrated care clinic for pregnant and postpartum women with substance use disorders and comorbid other mental health disorders. So we'll talk about the Hope Clinic, and I don't have any financial disclosures to disclose. This is a paper, if you're interested, that talks about some of the stuff I'm going to talk about. We published this in 2019, and an updated version is coming out later this year that talks about psychotropic medications, but also psychiatric pathology in pregnant and postpartum women, if you want to sort of expand more on this topic. So our objective in this short talk is to talk about psychiatric disorders and the risk of no treatment and suicide in pregnancy and the postpartum period, the importance of approach of a biopsychosocial treatment approach, both biological, psychological, and social and environmental factors that could really influence proper care, proper screening, assessment, and care for this patient population. So let's start with a clinical vignette. I sort of want you to picture a woman, a 24-year-old pregnant female, comes in, she's had multiple pregnancies, and she's at 7 weeks gestation. She has a past history of depression, anxiety, panic attacks, and she tells you she's anxious, she's moody, and she's just tired of it all. That's sort of the presentation. She's on these different medications, and she tells you that a month ago when she found out she's pregnant, she was 3 weeks pregnant, she just stopped all of her medications because she said, she didn't think it would be good for her or for her baby. And she doesn't use substances, but she's been smoking on and off to manage her anxiety. And she doesn't tell you what she's smoking, but you find out that she's smoking marijuana or weed, alaf. And then you do a tox screen and it's positive for, in the US, we have a fentanyl problem. I know, in the Middle East, it'd be maybe like opium or methadone. So this is the type of patient that presents to our clinic that's for pregnant postpartum people with substance use disorder. Someone that would be at a high risk of depression, of perhaps suicide. So this is sort of the type of person I want you to keep in mind as we talk about the patients that we're talking about. Let's talk about suicide just in general, some data. Suicide is a leading cause of maternal mortality during pregnancy and the postpartum period. A lot of pregnancy-associated deaths in high-income countries like the US and Europe are due to suicide. And the incidence of maternal suicide has remained stable or increased over the past decade. So, while other maternal mental health issues might have declined, suicide has not, and represents the leading cause of maternal death. When late postpartum death, that means so we call postpartum up to a year after delivery, are included. So some statistics on suicide. The prevalence of suicidal ideations in the postpartum period is about 3 to 5%. These are population studies that was higher on the higher end during the COVID-19 pandemic. Not surprisingly, this is a British study. The prevalent, and then this has also been shown by other meta-analyses. The prevalence of suicide attempts during pregnancy or postpartum is at 0.13%. This is a large US cohort study with higher risk in the postpartum period compared to pregnancy. And the risk of suicide and suicide attempts is markedly elevated in women with a history of mental health disorders, especially mood disorders, psychotic disorders, substance use disorders. So a patient that we presented would fall into this category. A history of prior suicide attempts. We're going to see this over and over, that the best predictor of future is really the patient's past. Low social support, exposure to intimate partner violence, and adverse life events. Additional risk factors include younger age, low educational attainment, unmarried status, sleep disturbance, inability to access professional support. Again, some risk factors. A significant portion of women with suicidal ideations don't meet criteria for major depression. So in that previous study, that was an English study, I think about 11% of these women actually didn't meet criteria for depression. So we need to screen specifically for suicide. We need to universally screen all women pregnant postpartum for suicidality, for intimate partner problems, recent arguments, depressed mood, substance use disorder, physical health problems. These are things that are more common in perinatal suicide deaths than in non-perinatal deaths. And the risk of suicide and suicide attempts is elevated in women with a history of mental health disorders, especially mood disorders, psychotic disorders, substance use disorders. Those with prior suicide attempts, as we just said, low social support, and exposure to intimate partner violence, and adverse life events. Other risk factors are younger age. So this patient was 24, for example, low education, unmarried status, sleep disturbance, and inability to access professional support. As Dr. before me was telling me in Iran, that seems to be the case, where the lack of access really seems to be an issue. So again, this woman fits most of the criteria we just talked about: substance use disorder, younger age, past history of mood disorders. And so you start getting a history from the patient, and you sort of do a diagnostic workup. And let's say in this patient, you find out that the patient has severe history of bipolar depression with multiple suicide attempts in the past, anxiety and panic disorders. And then you might, as a psychiatrist, you might decide whether or not to go the medication route. Again, like medication is a part of the biological approach, but also, pick a therapist, psychological approach, and then social environmental stuff that you would treat. And again, one thing that we don't want to forget to screen for is history of trauma and substance use disorder, because these things oftentimes come together. Now, why is pregnancy an important time to address? Pregnancy is a time of stress. Back in the day, we used to think that pregnancy might be protective. Someone, especially if it's a wanted pregnancy, this might be a pleasant time, a good time. If again it's a wanted pregnancy, the patient might not be stressed, they might not be depressed. We don't have to worry about anxiety. We now know that's not true. Allostatic load is a total wear and tear on the body, whether it's with positive stress or negative stress. Positive stress are things like graduation, a wedding. Pregnancy definitely falls into those things. These could be wanted things that regardless are stressful. And anytime your body is stressed, the chances, especially if you have a predisposition of having had other mental health issues, the risks of worsening depression and anxiety are higher, or just mental health in general, or mental health pathology in general is higher. So we now know that pregnancy and postpartum are not protective. People are at a risk of relapse of symptoms, and these are times where we need to pay closer attention to our patients, pull them closer, and screen them further. Again, pregnancy is, you're physically stressed. If it's your first pregnancy, it's the first time going through it. If it's a second pregnancy, third pregnancy, there's multiple kids at home. Those are stressful events, hormonal changes, bodily changes, life transition changes. So it's a time of stress. And then, usually we take a psychiatric history, medical history, look at what's worked for them treatment-wise before, look at how the patient's presenting, family history, social history, substance use history. But the timeline is also important. Is this person pregnant now? Are they planning pregnancy? Are they postpartum? Which would again give you different data and might alter your care and how you decide to what modalities you use in treatment of your patients. I'm a psychiatrist, so a big part of what we do is psychopharmacology. And one question is, at what point do you start or treat patients with psychopathology with medications? And it really depends on severity of disorders, history of response to treatment, patient preference and attitude towards treatment, effects of ailment on patient and fetus. So I kind of want to highlight this because a lot of what people worry about is, especially with psychopharmacology in pregnancy and postpartum, is what would be the effect on this patient, and what would be the effect, especially on the fetus. What is this medication going to do to the fetus? And sometimes that is very, very valid. Things like Depakote or valproic acid are known teratogens, and if the patient's on it, it could be really detrimental to the fetus. And so you don't want any woman of reproductive age on valproic acid, for example. If in this patient, for example, bipolar disorder, we do not want her treated. If she's on it, she should certainly be off of it. If someone of reproductive age is on valproic acid, you want to have very robust contraception. Multiple contraceptions. In countries like France, it's illegal for women of reproductive age to be on those on that specific medication. So the thought is important, but what's really important that's oftentimes missed, even by our colleagues, is risk of no treatments. Because everyone's so worried about a little bit of this medication, a little bit of that medication. What we forget is, what is the risk of no treatments? And what I'll do for the majority of this talk is not so much focus on suicide that we started talking about, but focus a little bit about psychopathology, especially in pregnancy and postpartum, and the data we have on that, because that's sort of like knowing how to treat, how to assess, and how to treat the underlying problem so that we would prevent suicide. But one risk of no treatment with medication, with therapy, looking at psychosocial factors, is return of pathology, worsening pathology that, as we just talked about, could lead to things like suicidal relapse of suicidal ideations, suicide attempts, substance use disorders that could lead to death, so on and so forth. So risk of no treatment is something we should be talking to our patients about. We should be talking to our colleagues about, and it should be a part of your consent. We talked about risks. When you talk about medications, you talk about risks, benefits, alternatives, and risk of no treatment. In the US, it's a very litigious country, and so the notes are very thorough. But it's also important about what you discuss with the patient or your colleagues. And risk of no treatment is something that we should definitely talk about and document. And who are the patients we would not treat or discontinue medications on? Those usually are people with mild illness. And you'd monitor them very closely and in conjunction with non-pharmacological treatments. Now, if you decide to use a medication during pregnancy to treat an underlying disorder, you want to pick medications that are well studied for reproductive safety profile to the extent that's possible. If possible, you want to make the changes prior to pregnancy. So this is why it's important to know if the patient's pregnancy planning, if they're pregnant or postpartum. And you want to sort of make the changes prior if it's possible, so you can limit the number of medications to decrease exposure of the infant, And for example, maximize one medication when possible prior to adding a second, or if you can, remove a second or a third. Now, in the US, 45% of all pregnancies are unplanned. So I usually talk about this in most of my talks because we just talked about how you'd go about picking medications. But if you know that 40 you're depressed during your pregnancy, it just does not allow for your body to function like it should. You're making a new human. If you're not eating as much, your baby won't grow as much. Preterm deliveries are more likely to happen lower birth rate babies, small for gestational age babies. So that's depression. Bipolar disorder, again, same story. In pregnant patients, you have a higher risk of poor prenatal outcomes. So not just the mother and not just suicide, but also, like we just showed in depression, for outcomes. If it relapse of substance pathology, this leads to poor compliance with perinatal care, which again leads to the mother and the fetus being harmed. Again, with bipolar disorder too, about 70% of people that discontinue their mood stabilizing medications will have relapse of symptoms. So with people with moderate to severe disease, especially, you really want people to stay on their medications. So we talked about depression, bipolar disorder. Now let's talk about psychosis in pregnancy. Psychosis during pregnancy and postpartum, it's an obstetrics and a psychiatric emergency. Psychosis is very much like delirium. Oftentimes it's waxing and waning, so it comes and goes away. And so we need to really monitor closely. And if someone has newfound psychosis or worsening psychosis, they oftentimes need to be in an emergency room or inpatient. There's a risk to the mother, to the infant. There's risk of suicide, but also infanticide, which are just terrible events, obviously. And the reason is the psychosis can hinder the patient's capability to participate in prenatal care, cooperate with care, and they could change their reality and lead to devastating outcomes. We do have a national pregnancy registry for atypical antipsychotics, but you should also know this internationally. Anyone this is now not just antipsychotics; it's all medications. If anyone's on medications, we sort of follow the woman and the babies through time, and this is how we have a lot of data now on the safety of psychotropic medications during pregnancy. So this is. Okay, so women experience symptoms of anxiety more during the first trimester, and pathological anxiety can correlate to poor obstetrics outcomes, premature labor, low Apgar scores, placenta abruption. I realize I'm short in time and I want to leave some room for Q&A, so I'll move through the next slides a little quickly. Substance use disorder, again, several factors: younger age, history of trauma, comorbid psychiatric disorders, current or past or family history of substance use disorder, something that we should not forget to monitor. And again, many women with polysubstance use disorder might try to abstain from use during pregnancy, but again, because the time of stress, it is a time where people relapse. And if they have a lower tolerance, they can accidentally overdose. They could, if they're unwell, it could lead to suicide and death. So we just need to monitor these women very, very closely and make sure we screen them, assess them, and monitor them very closely. You want screening to be comprehensive, careful, empathetic, non-judgmental. So I just let patients know I ask the same questions from everybody, and screen them for things like substance use disorder. And again, you want your treatment to be biopsychosocial. You want to get a good history, as we talked about, including psychosocial history, including family history. And I just put this slide. It took me 2 minutes to think about some of my patients. We talk about medications, we talk about screening, but other things like finances, housing, food, transportation, access to money, access to pharmacy, access to a phone, legal issues, education. I was talking about going up or down on 5 milligrams of Lexapro to a patient for a while, and then I realized the patient's homeless. The first thing for them that night is to have a place to sleep. or to have access to electricity or heat if it's wintertime. And so we don't want to lose sight of the big things, social environmental factors, and psychological factors. Because again, as psychiatrists, we don't want to lose. It's not all about medication. It's not all about biological or social environmental factors. Psychological factors are important, and there's tons of different types of therapy. These I've listed as the types of therapy we use oftentimes in trauma and substance use disorder care, anxiety and depression, things that are short-term therapies that could be very helpful for especially transition to motherhood. And again, these patients are patients that have a lot of need, right? They need a psychiatrist, a therapist, OBGYN, pediatrician, a social worker, so on and so forth. And so they're very vulnerable. It's a very vulnerable time, and they have a lot of needs. So what we found is that what the data shows is that the more integrated, the more collaborative the care is, the more the providers communicate with each other, the better it is for the patient. So again, when we keep this patient in mind that we just talked about, hopefully it's sort of, you get a broad picture of the importance of screening, assessment, diagnosis, the importance of biological, psychological, and social environmental factors, so that we could, and the risk of no treatment, so we could prevent suicide in pregnancy and the postpartum period. These are my references. I put the references related to suicide specifically in the last slide. And I'll stop there for question and answer.
Thank you very, very much for your very well-structured presentation. We're open to question and answers. You can write them in Q&A. There was one question. I think you also have access to the Q&A. They said if it's possible, could you give the website link where the psychotherapeutic drugs which are allowed for pregnant women?
Sure. So if you actually Google my name and do perinatal psychiatry, that's going to come up. But women's mental health, I think when you put this, .org is a website where, so Dr. Ruda Nonax is the chief editor of the website. She's an incredible physician and extremely knowledgeable, and she does a beautiful job of summarizing the most. If you join the newsletter as well, she does a beautiful job of summarizing the most updated articles. So you can literally put in different medications and pregnancy, and they'll give you the most updated articles in short with a summary, which is very helpful.
And then there's another question. How do postpartum depression and postpartum blues impact the rate of suicide? And should we still be concerned about the effect of medication on baby as much as in the pregnancy?
So that's a beautiful question. Postpartum blues being, so the differentiation, postpartum blues, we think postpartum depression happens probably like around 15-20% of the general patient population, depression being a pathological clinical depression. Postpartum blues is the first 2 weeks people feel a little sad, a little dip, and then they bounce back, and all of these factors do increase chances of suicidal ideations, which could then lead to suicide attempts, or if they have other comorbidities, worsening of those comorbidities. Let's say someone just gets, let's say someone's in remission from their substance use disorder and they have the blues, and that's just enough to get them to relapse. That will then spiral the patient down to, suicidal thoughts, even death, accidental death due to overdose. Just general. I tend to try to see my patients the week after, as soon as possible after delivery, because again, to your question, if the suicide, postpartum depression or postpartum blues happens, that does increase chances of suicidal ideations and suicide attempts. But again, and you don't even have to meet clinical depression. There's 10%, 11% of our patients, that patient population, didn't meet the criteria for clinical depression, but the patient might feel suicidal. And so generally screening patients with a known mental health history, whatever that might be, for suicide is extremely important.
Okay, and then the last question, we have one which asks, in pregnant mothers who are borderline for depression, is the DBT approach alone enough to control suicidal thoughts?
So that's an amazing question. I think I'd go, dialectical behavioral therapy obviously works very well for a multitude of patients, including patients with depression, including patients with personality disorder. So DBT is a great way of going about it. I expand, their the mother class where is also extremely helpful. They're down the diet and sort of developing better coping. Oftentimes people have been ready for that. It's not do level therapy, and there's a thing called seeking. That might be what you need, is sort of like, who are your, what is your safety plan? I think with suicide, those are, if someone's thinking they have suicidal ideations, the most imperative thought is the practitioner's practice of doing a proper screening, doing proper assessment, and then making a safety plan with the patient. So it's not even that deep into getting that therapeutic, talking about cognitive restructuring. It's using cognitive restructuring, but the idea would be to provide a robust safety plan, look at who their social support is, bring the social support into the family, talk about the partner, because oftentimes you talk about the mother and the fetus, but who's the partner? The patient's partner should be their family, their social support, so that there's multiple eyes on them, because oftentimes people around you might see things before you feel it yourself. And so we talk about that to the patients. But anything that the patient can benefit from, anything the patient has access to, DBT, CBT, just even support. Thank you so much for your question. And pregnant person suffering from aggression, discrimination. The stigma is a massive issue. I'm sorry, I just skipped their names. Stigma. So I think this is international. This is the things we suffer from. Stigma. I think a lack of understanding. Like, could you imagine a world where when men would get pregnant, or that we would go through getting our periods, it would be a different world. There would be like picket lines, there'll be signs everywhere. The world would be a different world. We will only work 3 weeks out of the. And so, we don't understand, and we don't have an appreciation for. And I think it's on men and women to sort of understand that we need to sort of cater to the women's needs, to understand the difference between what men go through and women go through, and really create a world in which we protect everybody. And aggression, discrimination, stigma are massively problematic. I think what you said over controlling husband, but intimate partner violence, which we alluded to, is a big problem. And these are, again, stressful times for the mother, but also for the mother's partner. And so, oftentimes people get into arguments if they want to buy a new couch for their home. Now a new baby could really make things difficult. And if the husband has psychopathology themselves or not, or the partner in general, intimate partner violence is a big problem. And like we were saying, you don't have to have depression. You can have a very problematic, unsafe home with a controlling partner, a violent partner, and that would lead you to suffering. That would lead you to depression. That would lead you to a relapse of substance use, or that would lead you to suicidal ideations. And so you make a very, very good point, and I think it's one that's not just it's not not just Iran. I think this is sort of like internationally a problem.
Okay, thank you very much for your answers. It was very nice to have you here. We're gonna have to move on to the next speech now as the time slot is over. Hopefully we will be able to make use of your great knowledge later in some future events and all of that.